If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? It's your man, Dr. Kyle. Welcome back to the Driven Athlete Podcast. Really interesting topic. I feel like something that we have worked a lot on is shoulder pain with throwers. All right. So especially shoulder pain at layback. And that would be like when the arm is all the way rotated backwards about when they're about to throw, as they're loading to throw. So it'd be like late cocking or a layback is what that would be termed. And if you ever look at like a picture of a Major League Baseball player or just a high level baseball player, when they're pitching or they're throwing, their arm is really far backwards, right? That's that full shoulder external rotation. It's actually really important. So anyway, a common thing is pain in that position where it's like when I get all the way back to layback, that's when it hurts. Or like when I get to like acceleration, mid-acceleration, that's when it hurts. And a super common, that's a really common thing. And locations for that pain is oftentimes the front of the shoulder, the medial elbow, and then sometimes the posterior shoulder, right? Just in the shoulder. So the things that we have to look at that are differentially diagnosis is like, where's the pain and when does it occur, right? So they say, hey, I'm a pitcher, or I'm a volleyball player, I'm a swimmer, an overhead athlete. We're going to stick with thrower just for the sake of this podcast, this topic. And they say my arm hurts when I throw. It's like, all right, that's a common thing we hear. Imagine going to a just a standard doc's office. They're going to say, all right, rest and just ice it down and then take some Advil, right? They're not even going to ask like, when in your throw does it hurt, right? Like when? Just it hurts when I throw. Standard rotator cuff involvement, right? Let's just start some imaging. It's like, bro, we got to look at other stuff. And maybe ask a question of like, when does it cause pain? And then also where located in your shoulder does it cause pain? That totally changes the trajectory of our treatment protocol, maybe in the angry tissue, that what's pissed off, like what's angry, what hurts, and then what mechanics are causing that to be the problem, how chronic has it been, what's the age of the athlete, like, and their skill level, their development level. But all that stuff totally changes the trajectory of like, okay, how are we going to fix it, right? What manual therapy stuff are we going to involve to intervene with? And then what corrective exercises are we going to involve? That totally changes everything, man. So it's just super important that you find a practitioner that's going to be like, oh, it hurts when you throw. Okay, tell me more. When? What's it feel like? Where's it located in your shoulder? How long has it been going on? That totally changes everything. So anyway, so what we're going to ask is when and where, what's it feel like? And they say, let's say, for example, it hurts at layback at full backwards range of motion, or they call that full external rotation. And it hurts in the front of the shoulder. Super common. All right. One of the first things we're going to look at for testing is the range of motion and pure external rotation. All right. So we're going to bring their arm up into their throwing angle, right? In addition to that, we're also going to ask like, hey, show me your throw. Because throwing mechanics are different for everybody, and their arm angle, their arm slot is going to be different. So like some people have a very low arm slot, we're throwing more sidearm, and then some people have a very high arm slot, throwing more overhead, like a Ferris wheel versus like a merry-go-round, if you can visualize that. So it's important to look at their mechanics, right? Like I'm not going to change their mechanics, or like they're throwing, if they're like a high-level athlete in their college or like a late high school, I'm not going to be like, we need to totally change your throwing mechanics. I'm not a pitching coach. But biomechanics and pain, that's what I do. And if they have pain and they're a younger kid and they're throwing two sidearm, we might suggest and influence, be like, it might be better for you to raise your arm slot a little bit, especially at this young age. You're influenceable like that. So that's what we're gonna ask. Like, show me your throwing form. So they say to throw it, and they say it hurts. At the layback, at the very front of my shoulder. We're gonna check their shoulder passive range of motion and pure external rotation. Oftentimes, throwers are limited in external rotation. All right. They have a lot, right? But it's a natural accommodation for the athlete to be able to do that high level throw at that high level velocity. in order to have the best mechanics possible and to spare their arm and the structures in their shoulder. So it's super important that they have enough shoulder external rotation. We find ourselves intervening to get more external rotation for them. All right. They're actually limited. They need like 140 to 130 to 145, 150 degrees of pure external rotation in their shoulder. It to get back there to have the right throw mechanics that they need and spare their arm. A lack of pure shoulder external rotation, it stresses other structures to overcompensate. And that's what gets painful. And that's why we're intervening with what we do, right? And oftentimes people ask like, okay, what hurts? Well, with anterior front shoulder pain with a thrower at layback, it's very commonly the biceps tendon that's just irritated and painful. It's getting chronically over lengthened, and it's chronically required too much stability of itself of that structure when that's not really what it's designed to do, and that causes pain right in the front of the shoulder. So the long head of the biceps tendon traverses up the shoulder joint and attaches to the supraglenoid tubercle of your scapula. All right, and that is where the biceps anchor of the superior labrum is. All right, so your biceps tendon actually has an attachment to the superior labrum. So if somebody has like chronic biceps pain, it seems to be an increased risk of a slap tear in their labrum. The slap tear means superior labrum anterior to posterior, SLAP, slap. And that's the connection with the biceps anchor to the labrum at the top of their shoulder joint, all right, in their shoulder glenoid. So that's the influence of the biceps tendon in the labrum and the slap tear. All right, that's where that comes from. Interesting fact, slap tears are really common in overhead athletes. Like 80% of overhead athletes have some kind of a slap tear labrum involvement. If it's mild to moderate, some kind of level. So it actually is really common, but you don't see 80% of throwers having pain all the time. So the structural abnormalities aren't always correlated with a lack of functionality and pain and the trajectory of like their athletic career. Slap tears are really common. Just the same message as before, as we talk about with like lumbar disc herniations or cervical disc herniations. There's plenty of people that have herniated discs and they have no pain and they're totally fine, right? So there's a disconnect between imaging abnormalities, structural abnormalities found in the image, and the actual pain and functionality and trajectory prognosis for somebody. But anyway, so that's the involvement and the correlation between the biceps tendon and the top part of the labrum. So as somebody goes back into layback, there's a lot of torque and rotation involved in the shoulder and tensile tension against the biceps tendon, against the biceps anchor labrum. So if somebody's lacking pure shoulder external rotation at layback, there's going to be more anterior translation of the humeral head. All right. The humeral head is going to slide forward excessively. And there's only one major structure, one structure that's active that prevents that on the anterior side. And that's the subscapularis muscle. All right. The biceps tendon traverses the front part and it contributes a little bit to anterior stability, but that's not its main job. And with the rotation component added into it, that just causes a lot of stretch strain and it can cause a lot of irritation to the biceps tendon. So anyway, that's why it gets lit up. It's hanging on for dear life, and it's not supposed to be doing that kind of stability requirements for the anterior part of the shoulder, the front part of the shoulder at layback. All right. The anterior capsule, the joint capsule, also is what gets irritated. There's a ton of nerve endings in the joint capsule of the shoulder, of all joint capsules, all right, and the shoulder being one of them. And all those nerve endings are super sensitive and they get irritated. So if the anterior capsule is getting chronically stretched and overly stretched and strained, and it's overly stressed with that excessive anterior translation of the humeral head, the biceps tendon is going to get lit up and the anterior capsule is going to get lit up. And that's why the front of the shoulder gets really tender and hurts. That's where the pain comes from. All right. But we're thinking like, okay, why? The biceps tendon is lit up. The anterior capsule is lit up. I wouldn't be surprised if the supraspinatus, like part of the rotator cuff, is lit up too, because it's just overworking and overwhelmed. That's a super common thing. It's almost understood. I guess the rotator cuff is probably going to be involved in some capacity, a little bit. But anyway, the question we ask is why? Why what is this thrower doing differently that's causing the biceps tendon and the anterior capsule get lit up? We know what the angry tissue is. That's not that hard to figure out. But the question is like, why? And as a biomechanics and pain experts that we do with athletes, that's what we're trying to figure out, because that's what we're going to fix. What's the cause of the cause? All right. So the biceps tendon gets lit up, the anterior capsule gets lit up, and it's from excessive anterior translation of the humeral head in the shoulder joint, in the shoulder girdle, in relation to the glenoid fossa. That's where it articulates with the scapula, or the shoulder blade. So that excessive anterior translation, we would call that anterior instability or anterior hypermobility. So shoulder hypermobility, that's standard. That's a common thing. The shoulder joint is super hypermobile. It's very unstable. All right. So excessive anterior translation, that also can create posterior impingement. All right. So if the front part of the shoulder joint is somebody goes into layback like this, and the shoulder joint glides excessively forward to overcompensate for a lack of shoulder pure external rotation range of motion, the posterior contents are going to abut against each other early or excessively. And that abutment of the posterior rim of the glenoid part of the bone of the scapula and the humeral head, that causes posterior impingement. And that's why the posterior shoulder pain occurs commonly with this at layback. It was like, when I go all the way back, it hurts in the back of my shoulder. It's excessive anterior translation and anterior instability, hypermobility of the shoulder joint. Okay. And the posterior contents are getting abutted into each other, and that would be posterior impingement. And the structures that get posteriorly impinged would be the infraspinatus, teres minor, and the posterior capsule. So those guys, those soft tissues is what's getting angry and irritated and pinched or impinged upon with with excessive anterior translation at the layback. But why again? It's because they're lacking pure external rotation. We can always work on strength and stability. So we would call this, it's an anterior shoulder stability problem. All right. And there's one muscle that really stabilizes against this excessive translation anteriorly as they go back and layback. And that muscle is one of the rotator cuff muscles, and that's called your subscapularis. The subscapularis rotator cuff muscle is located on the ventral side of the scapula, and it spans across the anterior part of the shoulder joint of the humeral head. And that's the only active tissue that's main job is to prevent excessive anterior translation. So very commonly, that thing's going to be tight and weak. It's going to be bound down, or it's just not going to be active as best it could be, and it's going to be inhibited. It's not going to be super strong and recruitable. So we have to activate that muscle more, get it stronger, get it more activated with functional movement overhead, especially external rotation, to allow the shoulder to rotate backwards and external rotation without excessively just shifting forward at the same time. That takes just some time to work on, right? We also have to improve its pliability, all right? We have to lengthen the muscle pliability. We have to improve its pliability. So we have to do a subscapularis release too. That doesn't feel good. And maybe even dry needle it as well, if someone's cool with that. So we're going to dry needle, we're going to release and work on the pliability, the extension pliability of the subscapularis, the flexibility, dry needle it, and then also work on posterior capsule lobes of the humeral head to reseat it in a better position and re-educate it to be to rotate in a more established center of rotation. We call that PICR, path of instantaneous center of rotation. And then also work on some posterior rotator cuff soft tissue work. And then the subscap MET, and then subscap exercises on the gym floor that we're going to do, corrective exercises with overhead movement and with external rotation. So that, anyway, that's where our head's at with that. That's what our brains are thinking. If somebody comes in with anterior shoulder pain as a thrower, one of the first things we're looking at is, do they have enough pure external rotation? Having enough pure external rotation is going to solve all those problems. It's going to prevent a lot of those problems that's the best recipe. So an interesting thing with that is GERD. If y'all have ever heard of GERD, all right, GIRD, glenohumeral internal rotation deficit. So the shoulder joint rotates, right, like this. Okay. And if it has excessive amounts of external rotation, the thought is they're lacking internal rotation because the shoulder joint has developed and proliferated into accommodating more pure external rotation. So the thought would be like they're lacking internal rotation. Well, that is understood to be the case. That's going to be totally understood, expected, right? But I'm not going to work on more internal rotation. All right. GERD is actually a good thing for shoulder overhead throwers like baseball players. All right. GERD is a good thing. It's an accommodation that they need to throw well and have the best mechanics possible with that high velocity, high torque rotation throwing motion. It's an adaptation of three things. All right. It's a bony adaptation where the humeral head actually develops more in a retroverted position. So that's going to be a common with imagine like a young kid who throws and plays baseball a lot. I mean, all the thousands and thousands of throws they've done, that influence and torque influences the growth of the bone through adolescence. So I imagine something like goes through adolescence years and puberty, like as they learn how to throw, like maybe it's like an 8-year-old who then throws for their whole life, and now that they're in college at 22, right? That's a long time, right? That's 14 years. So bony changes get influence in that direction, is to accommodate all the stress that they've been going through. All right. The other one is soft tissue development. So like the joint capsule itself develops to get more lax in the anterior direction, and then it gets bounded down in the posterior direction. Or sorry, in the opposite direction, the posterior structures. That's to accommodate more external rotation again. All right, and then the other one is just muscular. So the muscles get more developed and tight with the posterior structures, and then also in the anterior ones, they get more pliable and lax. But over time, compensation patterns happen, and maybe throwing mechanics change, and overly doing overtraining can happen. Like at some point, you gotta modify training, right? Overtraining is always going to be a concern, but at some point, you got to back it down a little bit, right? Even the pro athletes will back it down a little bit to allow things to settle down. It wouldn't be smart to just train through, but anyway, so GERD, glenohumeral internal rotation deficit, is actually an expected good thing for throwers. We're not going to work on more internal rotation. So as an example, I'm not going to do sleeper stretch with athletes. I'm not going to do the behind the back rope pull with athletes, or the elbow forward stretch with athletes, or with these throwers. We're going to work on more external rotation actually. And that's going to prevent a lot of future issues and resolve their pain, right? That's what the ultimate goal is. So what happens if somebody lacks pure external rotation? Well, they have more anterior translation or anterior shifting of the shoulder joint. They have more hyperangulation at layback. All right. So that'd be like the W posture, the W throwing position. All right. So like if somebody throws and their arms out like this, they're going to retract their scapulas more, and they're going to horizontally abduct. All right. They're going to horizontally abduct their shoulder, and that just creates even more anterior shift of their shoulder joint, and that's no bueno. Steven Strasburg was he was a pro pitcher, and he was really known to have that W posture. The thought would be like that hyperangulation position. It just creates more anterior shift and more stress and strain on the anterior structures of the shoulder joint. That has been also correlated with medial elbow stress. So medial elbow stress, as an example, like Tommy John issues, that's the anterior band of the UCL ligament in the elbow. So the ulnar collateral ligament, and there's an anterior band of the ulnar collateral ligament, and that guy gets overly stretched and strained with a lot of valgus forces, which would be this position here, where imagine like shifting your arm inwards all the time and your elbow goes forward. That valgus stress on the elbow stretches and stresses the anterior band of the UCL. And imagine doing that thousands and thousands of times at a high velocity. It's going to cause some changes and maybe some issues. And then it can cause a ligament injury at the UCL. And that surgical repair is called Tommy John surgery. All right. So a lack of pure external rotation seems to be just a foundation for a lot of these issues to develop. Biceps tendon pain, anterior capsule pain, and excessive anterior shift of the shoulder joint. Anterior translation is what we will call that. Hyperangulation at the shoulder with the throw at layback with that W position, creates even more anterior shift, and then more medial elbow stress. And the last one is oftentimes athletes will hyperextend their low back. So like lumbar hyperextension and hyperextension rotation. So another common thing for athletes is with throwers is they get back pain, right? They excessively hyperextend their lumbar spine and rotate their lumbar spine with the throw motion. It's because they're overcompensating to get back far enough as they need to. And the thing we're going to check out if an athlete is their shoulder rotation, their pure external rotation range of motion, even for an athlete coming in with back pain. If a pitcher comes in with back pain, we're checking out their shoulder for sure. That's what they do, right? Their shoulder is their main driver and the torque that they do with their throw. And if they their back hurts with throwing, we're definitely checking out pure external rotation range of motion for their back pain. So it's just a compensation. It's interesting how these compensation patterns lead to manifestations of pain elsewhere. So that's just where our brain's at and looking at that stuff. So the other things that include, here's the last thing I was going to talk about. The other thing that is important to investigate is with a lack of pure external rotation, they're getting rotation somewhere if they're getting back there. The thoracic spine also needs to rotate, and their scapula needs to retract in order to get up into full layback and their arm slot. So their scapula retracts and their thoracic spine rotates and their shoulder joint externally rotates. We would call that the MER, M-E-R, the max external rotation. So when you see the poster or the picture of a pitcher in baseball, when they're at their full stride and they're at full layback or late cocking position for the throw, they're like way back there. Their shoulder isn't the only thing rotating. Their thoracic spine needs to extend and rotate, and their lumbar spine needs to extend and rotate, but it's mainly, we're going to look at the thoracic spine. And then their scapula, their shoulder blade, needs to retract and upwardly rotate. So all those things need to be functioning well in order to get to a full layback position and as best they can and as efficiently as they can and not have pain. So we're also going to look at the scapula for sure. And we also need to work at the thoracic spine rotation for sure. It's not always T-spine extension rotation. Sometimes it's flexion rotation. But for layback, we need to look at the rotation range of motion for the thoracic spine. And that would be the MER. All right. So exercises that we work on, we need to work on their scapula, upward rotation and retraction, which is a tricky thing to work on. It's not that, it's just something that people don't consider, but we've had really good results with athletes when we work on upward rotation and retraction at the same time, and then also thoracic spine. And we can't neglect that part of that is core stability, all right? So it's just interesting to look at all these factors to help an athlete that has anterior shoulder pain, all these pieces to the puzzle that contribute. And we don't want to leave any stones unturned as to like, why this athlete that developed shoulder pain like this? When the answer of just overtraining, that can be a factor for sure. But if it's just too much, take a break. You're working too much, just rest. That's a cop-out answer. The reason is because all of his pitcher teammates, they're throwing at the same volume. They don't have the same shoulder pain that this other athlete does. So what is this athlete doing different, right? They're all throwing the same amount. Why don't they have shoulder pain the same way that this person has shoulder pain? It's because this guy's doing something different. And those compensation patterns we need to figure out, and we need to work on intervene that appropriately with a recipe of the purposeful manual therapy, some soft tissue work, muscle activation and recruitment, and then stability corrective exercises out in the gym, right? All those things, that's the best recipe, and that should translate to their functional throwing motion that we're going to later stages work on too. But that's the best recipe to actually fix shoulder pain at layback. And that's what we need. That's what we have to investigate and differentially diagnose. And it's going to totally change the trajectory for different people based on their shoulder pain and all the stuff I mentioned in the beginning. So those are just things that we got to consider. So that's just a little sneak peek and snapshot on like what's going on in our evaluative process, differential diagnosis, where our brains are thinking if somebody comes in with shoulder pain as a thrower. So if you have any questions, don't hesitate to reach out. We're always open to suggestions, comments, questions, concerns, conflicting opinions. And if you have any questions yourself, if you're battling pain, don't hesitate to give us a call, reach out on our website. You can DM us on Instagram. Our phone number is 561-899-8725. Don't hesitate to reach out to us. And our email, the best email to reach us is team, T-E-A-M, team@athleterc.com. And we're always excited and optimistic to help people and open to having conversations. So feel free to reach out, and we'll catch y'all next time.